Hi everybody, Dr. Batash here. I want to welcome you to our fourth BEWL podcast, where we discuss everything and anything that can be related to endoscopic, non-invasive weight loss. Today, we're going to be talking to our Director of Anesthesiology, Dr. Mark Abel. He is my oldest friend and my best friend in this world. He is someone who's been practicing anesthesia for over 30 years. He was formerly the director of liver transplantation anesthesia in both Mount Sinai and Montefiore hospitals. And we are going to pick his brain today to see how he approaches the endoscopic weight loss patient, because these patients all require anesthesia. For the balloon patients, in general, we use local forms of anesthesia, whereas for our Suture Sculpt patients, we only use general anesthesia with intubation. So here we go. Your endoscopist, Dr. B, that's me.
That's you.
Right, has determined that a patient is appropriate to be done in our facility. And, obviously I take a full history, medical history, surgical history, what medications a person takes, what allergies she has, and I have deemed the patient to be appropriate for our facility. And you are about to go interview the patient right before we bring them into the procedure room. I, as a patient, what kind of questions should I be expecting from you? How are you going to look at me? And how are you going to determine if I'm a good patient for this procedure?
So we ask mainly about past medical and past surgical history. This is where our interview is focused. We start asking about past surgical history, any operations the patient.
Why is that important?
It's important for two reasons. Number one, if somebody's had surgery on their cervical spine, let's say, for example, the particular site of surgery may impact our airway management.
I've had surgery on my neck, so it's good to know.
This would be something that I would speak to you about.
But I can move my neck really nicely, I think.
And that would be reassuring to me.
Thank you. Okay.
But it's something we would talk about.
Okay, go ahead.
The other reason surgical history matters is we like to know how patients respond to anesthesia. Do they tend to have a lot of pain? Do they have nausea and vomiting after anesthesia? This is something that we pay very close attention to. And then we move to the medical history. The things we usually talk about are the more common problems: cardiovascular disease, blood pressure, respiratory problems ranging from asthma to chronic bronchitis.
Does my asthma need to be under perfect control?
Your asthma does need to be on perfect control, because after we put that breathing tube in, we don't want the lungs, the bronchi, the tubes in the lungs to go into spasm. This is something that we want to prevent. And then once we've moved on from those problems, we talk about endocrine problems like diabetes, maybe thyroid disease, and then other less common problems that may impact our airway management, let's say. Rheumatoid arthritis or any other arthritis. We talked about the neck. This is something that we might...
Why is rheumatoid arthritis or lupus, why is that important?
Well, rheumatoid arthritis is particularly important because it may impact our ability to put the breathing tube in. Rheumatoid arthritis is particularly tricky in that even if somebody appears to be able to move freely on the outside, there could be frozen structures on the inside that you won't know until the patient's asleep. So you must be very careful. Other illnesses like lupus, you mentioned, can affect organs. Any organ, but particularly the kidneys we would worry about with lupus, for example.
Mm-hmm. Okay. Any medications that may worry you with a patient when you obtain the history?
Yes. Certain common blood pressure medications are not a problem for us per se. Angiotensin converting enzyme inhibitors, angiotensin II blockers, they're not a problem per se, but we like to stop these the day before surgery because they can cause rapid hemodynamic swings, particularly low blood pressure. So we stop them, and then they're not a problem.
And I've learned the hard way. That's something that I learned. several years back.
Other drugs we might worry about are blood thinners, which could impact you and your part of the procedure.
Correct.
So it's very important that we know what...
Diabetic medications?
Diabetic medications are not generally a problem. We used to worry about metformin, but I don't think we worry about that so much anymore. It's been shown to be safe. We certainly want to make sure that patients are complying with their diabetes medications and that the dose that's been recommended to them is proper so that the sugars are not too high or too low.
Yeah, so I agree. I mean, we had a couple of patients recently whose diabetes had been undiagnosed prior to their coming to me. And when we did our routine screening blood work, we found out that their diabetes was way out of control and their sugars were 400, 500. And obviously those patients' procedures were delayed until their sugar is under good control. Do you worry about any allergies?
We always ask the patients about allergies. As part of our procedure, we routinely give an antibiotic called levofloxacin, but other allergies also we need to ask about. Occasionally, on rare occasions, people can be allergic to one of our anesthetic agents. So we ask about allergies in general. We ask about allergies to anesthetics. We ask about prior adverse reactions patients may have had to anesthesia or that their first-degree relatives may have had to anesthesia.
Why is that important?
There's something called malignant hyperthermia, which is not an allergy per se, but it's a very dangerous, life-threatening...
I hear about that all the time, but I've never seen it ever in my life.
So I would say that I've done about 50 to 60,000, maybe as many as 100,000 anesthetics in my career, and I've seen it once. Okay. The incidence is not common. It happens about 1 in every 20 to 1 in every 40,000 anesthetics, depending on which literature you read, but it's 1 in 20,000 to 1 in 40,000. It's not common, but a busy anesthesiologist will probably see it once in a career, and this is something that we want to avoid if a patient has a known history of it, and if not, it's something that we're equipped to deal with in our facility.
Okay. So recently, if you remember, I discussed a case with you where a lovely young lady who would have been a wonderful candidate for the Suture Sculpt or the Endoscopic Sleeve gastroplasty, when I asked her about anesthesia, she said, yes, I am allergic to anesthesia, and on deeper questioning, she told me that she was diagnosed with malignant hyperthermia. Is that the kind of case when you have a patient with known malignant hyperthermia? One, should that be done in an outpatient facility, number one? And if the answer is no, can it be done safely in a hospital setting?
So the answer is no. It should not be done in an outpatient facility, although it probably can be done in an outpatient facility. It's much safer to do it in the hospital. And in the hospital, it's much safer. They have anesthesia machines that have not had anesthesia gases running through them, one of what we call the triggering agents from malignant hyperthermia. So they have these clean machines in hospitals. They have support ranging from intensive care units to very high technology monitoring in the recovery room, monitoring in the operating room that we can't do in an outpatient facility. So eliciting a history like this of malignant hyperthermia is very important, and we would send a patient like this to the hospital.
Okay. Just a quick question for our patients who sometimes ask me these questions. Succinylcholine versus rocuronium.
So we talked about triggering agents from malignant hyperthermia. In terms of malignant hyperthermia, succinylcholine is a triggering agent. Rocuronium is not. These are muscle relaxants that facilitate the placement of the endotracheal tube and potentially lack of movement during the procedure as well. Rocuronium is what's called an intermediate-acting, non-depolarizing drug. Succinylcholine is a short-acting, depolarizing drug. To make a long story short, rocuronium sticks around a little longer. It needs to be reversed, and the reversal agents, although they're very effective, come with another set of problems, which is primarily nausea and vomiting that you don't get with succinylcholine because you don't have to reverse the succinylcholine.
Right. Who should make that decision? Because very recently I had a very knowledgeable nurse as a patient. We did her Suture Sculpt and she did extremely well, but she had a very long discussion with the anesthesiologist. She was insisting on getting rocuronium instead of succinylcholine. Ultimately, whose decision is this? Is it the patient's decision or the anesthesiologist's decision?
Certainly, as an anesthesiologist, I would never do anything that a patient refused.
Of course.
So if a patient refused succinylcholine in spite of my recommendation, I would not give succinylcholine in spite of that. The patient is the boss over their own body.
Agree.
Succinylcholine is a short-acting drug, and it makes airway management much safer than intermediate-acting drugs potentially do. So succinylcholine is wonderful.
Okay. Another problem that comes up very frequently is patients will tell me, hey doc, I'm allergic to codeine, but I'm okay with Percocet. Or they'll tell you that I've only had narcotics once in my life, and they'll tell you specifically which narcotic they had, or they don't know which one they had, and they assume that they're allergic to all narcotic medications. Can you just comment on that? Because we need to use some narcotics for pain relief. What do we do in a case like that?
So most commonly when people tell you that they're allergic to narcotics, it's almost always a side effect rather than a real allergy. Nausea and vomiting is a common side effect that people experience that, of course, they do not like. Certain narcotics are more prone to cause nausea and vomiting than others, although certainly they all can. Certain patients react differently to certain drugs. So if somebody tells me, for example, I've had nausea and vomiting every time I've had fentanyl, but when I get Percocets, I don't have nausea and vomiting, I would tailor my narcotic administration to the needs of that particular patient.
Okay, fair enough. Sometimes I will have a patient tell me, doctor, I refuse to get general anesthesia. Please do this under MAC, or please do this under propofol. And when I'm talking about, what I'm talking about is specifically the endoscopic sleeve gastroplasty or the Suture Sculpt. What are your thoughts about that?
So I've worked with you for a while now, and I can keep somebody asleep for days, weeks, or months with a propofol infusion. The problem is it does not facilitate the kind of surgical field that you need. And so I
need calm in my field and no movement.
So the other anesthetics, MAC, it stands that you mentioned, it stands for monitored anesthesia care, which basically is sedation, mild to moderate sedation, or propofol, which is deep sedation. None of these things are deep. None of these things are full anesthetic like a general anesthetic. So I can do it, but it wouldn't provide you with the field and with the conditions that you need.
And I wouldn't be able to do my procedure.
So I would tell the patient that that's not an option.
Okay. What will happen
to her? Just to back
her?
up, the one thing we didn't talk about at preoperative concerns is substance abuse, and particularly smoking. Smoking can complicate the administration of anesthesia very much in terms of reactive airway disease.
So are you discussing nicotine? Are you discussing marijuana? A lot of people think that vaping isn't smoking. Just give me some of your thoughts on that.
Any foreign substance that's introduced into the lungs on a regular basis is a potential cause of respiratory problems, of reactive airways. In a more chronic scenario, it could cause long-term lung disease. So all of these things are a concern.
So would you agree that vaping is smoking? Because some of my patients don't seem to think so.
It is.
It is. Okay, I agree. Any set of challenges in somebody who is more than an occasional user of marijuana?
Marijuana,
in terms of anesthesia?
Sometimes people that are chronic users of any substance, including marijuana, might require more anesthetic. They become acclimated, not just to the substance that they're using, but they're acclimated to substances in general. So aside from the smoking issues associated with regular marijuana use, I would be concerned that the patient might need more anesthesia in the operating room, more post-operative pain relief. Not always, but it would get my attention.
If you had the power So for example, in a smoker,
Yeah.
let's say somebody who smokes a pack per day, would you require that they stop smoking for a period of time prior to your giving them general anesthesia?
So it's a funny question, because if somebody smokes every single day, I would like them to stop 30 days, 40 days before the procedure to give the lungs time to heal. However, people think that they're doing something good by stopping 3 or 4 days ahead of time. That's actually bad, because the lungs actually...
I was not aware of that.
I thought you might not be, which is why I mentioned it. Because in that particular case, you withdraw the nicotine and the lungs start to make lots of mucus in response to the acute nicotine withdrawal. And that's actually worse than just continuing to smoke. So cessation 30 to 40 days ahead of time, we like that. Cessation 3 to 4 days ahead of time, I would advise against
Question. Doctor, it's very hard for me to go cold turkey. Would cutting my cigarette use by 50%, let's say for a few weeks before the procedure, is that something that's helpful? I can't go cold turkey, but I can cut it in half.
I can't advise that any level of smoking is acceptable.
All right. So here we are. You have taken me into the procedure room. I'm really scared. I'm really nervous. I need a big hug. And I come into the procedure room. It's a very nice procedure room. It's very well lit. It's incredibly modern, but I'm still very nervous. What's going to happen to me now? What do you do to me?
So this is a very scary time. This is where the abstract concept of coming in for a procedure becomes very, very real. And it's very normal for people to be frightened. I try to do my part as quickly and safely as possible, which usually is under 10 minutes during this part. We have a lovely staff. We're very appreciative of the fact that these patients are nervous, and we calm them and we reassure them that it's normal to be nervous. While this is happening, I put some monitors on, I start an intravenous, and once those things are in place and proper...
Does the intravenous hurt?
The intravenous generally doesn't hurt that much. It's no more than a little pinch. Occasionally it can be technical to put an intravenous in certain people, particularly as part of being overweight. Difficulty in inserting intravenous's can be part of it. With that,
do you have a vein finder?
We do have a vein finder.
Lovely.
For patients that are difficult.
Okay, great.
And so we do all that as efficiently as possible and reassuring the patient that being anxious during this time is completely normal.
You've started the intravenous, you've put all the monitors on me. What's next?
I start to give medication through the intravenous, which make the patients drowsy at first. Okay. And that part of the drug administration goes on for about 2 minutes, I would say. Mm-hmm. And then we...
What do you typically use?
I use a combination...
If it's not a secret?
It's not a secret. It's not a secret recipe. We use fentanyl, which is a narcotic. Sometimes we use Dilaudid, which is another narcotic instead of fentanyl. Really six of one, half dozen of another. And we give a combination of medicines designed to prevent post-operative nausea and vomiting.
What kind of medications?
Something called droperidol. We give steroids. We give something called ondansetron, which is a very good antiemetic.
Zofran?
Zofran is ondansetron, right? And we give all these things. Some anesthesiologists give these things at the end. Some anesthesiologists give them at the beginning. I don't think the literature shows that it matters that much one way or another.
Do you use a patch? Scopolamine patch?
The patients come into the procedure room with a scopolamine patch. We give it to them before they ever come in. That way, by the time the procedure's over, the scopolamine blood levels are such that we have an effect from the scopolamine.
So essentially what you're saying to me is that you're trying to prevent nausea by hitting several different mechanisms.
Correct. So droperidol works through one mechanism, ondansetron through another, scopolamine yet through another, and the steroid yet through another. So we're using 4 different drugs that work through 4 different mechanisms, all designed to prevent post-operative nausea and vomiting.
Okay. What else?
And we're successful at it in the overwhelming majority of cases.
Okay.
Pain management is the other thing. As I mentioned, I use a narcotic, typically fentanyl, sometimes Dilaudid. And these are the drugs that I give up front just before putting the patient to sleep completely.
Okay. So at this point, is the tube, is the patient intubated?
The patient is not. We're having a conversation.
Okay.
I tell them, you're going to feel a little funny from the narcotic, from the fentanyl. Don't worry, that's normal. You'll be a little lightheaded. Most of the time, it's very pleasant. But I let people know that this sensation is about to hit them so that they don't think something untoward is happening. They expect it. The main thing in anything that we do in the procedure, what you do, what I do, is not to surprise people.
I agree.
If they expect it, then it's not that frightening.
So I guess the next step is intubating the patient, putting them on the breathing machine.
Well, so the next step would be to put the patient to sleep completely, to induce the complete loss of consciousness. We don't want to put that breathing tube in until the patient is completely out. So then I give something called propofol, which induces unconsciousness, and the muscle relaxant succinylcholine that I mentioned to provide us with a nice steady field in order to use that to put the breathing tube in. And after the patient is completely out, only then is the breathing tube put in. In a case of a difficult airway, do you also use other instruments to make it easier for you to see where you put the tube into? So we have emergency equipment available. We have something called a glide scope, which is like a rigid fiber optic scope, so the light can actually bend around corners, so we can see things with the glide scope that you might not be able to see with a conventional light bulb laryngoscope, for example. And then we have emergency equipment, or just equipment that might be used in a difficult situation that's not an emergency, something called a bougie. It's a leader. So we have all kinds of equipment available to help with airway management when the airway management is not routine.
Okay. So, and you are the director of anesthesia for BEWL, and if there's anything extra that you need, you please let me know, and I'll make sure that it happens.
I sure will.
Okay, great. Okay, so now the patient is fully asleep. The patient is on a ventilator. So that's when I take over. I do the procedure. On average, my procedure time is, let's say, on average about 45 minutes, give or take. Obviously, you monitor the patient during the procedure. What are the things that you monitor during the procedure?
So this is what's called the maintenance phase of anesthesia. I talked about putting the patient to sleep and putting the breathing tube in. That's the induction phase. During the maintenance phase, we use an anesthetic agent. It's an inhaled agent, and that keeps the patient asleep.
So tell us a little bit about the inhaled agents.
So these are called volatile agents. Everybody might have heard of ether from the Flintstones days.
Or from watching MASH.
Or from watching MASH. In those days, they used to use something called ether, which was a safe anesthetic drug. But we no longer use that for a variety of reasons. But the drugs that we use are safer, more modern derivatives of ether. They came from that. So we use these drugs to keep the patients asleep.
Why is that better to use these volatile agents as opposed to something like propofol? Or something like narcotic agents?
Some people do. With propofol, you can't maintain a deep enough anesthetic for a procedure like what you talked about. You can supplement the propofol with narcotics and do what's called total intravenous anesthesia, but that's really not appropriate in our setting. That would be for a much longer, more involved procedure. So in our setting, the volatile agents has the benefit of being easily reversible. It's what we call titratable. So you can increase the depth of anesthesia by turning a dial. You can decrease the depth of anesthesia by turning a dial, which takes us to your other question is, what do we watch for during anesthesia? One of the main things that we watch for once the tube is in and the airway is secured is hemodynamic variability. All anesthetics, surgical stimulation itself can cause hemodynamic variability. So these volatile agents help us titrate the anesthesia up and down. We can raise the blood pressure, we can lower the blood pressure, and to the extent that the volatile agent is not adequate to alter the hemodynamics the way we want them, we have medications, intravenous medications that can help us out too.
So clearly, even though during the suture sculpt or the endoscopic sleeve gastroplasty, I don't cut anything, I mean, the way I do the procedure is essentially I'll make about 100 full thickness little holes in the stomach through which I feed the suture material, and that's how we narrow the stomach, and that's how we shorten it. That's how we fold the stomach like the accordion. Would you say that what I do is just as stimulating to the patient as the actual cutting that a surgeon might do?
Definitely not.
Definitely not. Okay.
Definitely not. Although you do require a certain depth of anesthesia for your procedure to keep the stomach still. I know that we've dealt with this. When the anesthesia gets a little bit light, the patient's asleep, the patient's not moving, the patient's
I start to get
completely
a
unconscious.
nasty look on my face.
No, you never get a nasty look on your face. But you will comment that the stomach is moving a little bit, and I can deal with that by deepening the level of anesthesia. Mm-hmm. But the level of stimulation is nowhere near the level of stimulation you see when this procedure is done surgically.
So when you see, let's say, a surgical sleeve where they actually cut off at least 50% of your stomach,
they do.
In those cases, do they require a higher level of narcotic?
Sure, because two things. Number one is that there is something called a laparoscope, which is inside the abdomen, as opposed to just an endoscope, which is going in through the mouth and the esophagus. A laparoscope that's going into the abdominal cavity is much more stimulating than a scope, so they require deeper levels of anesthesia, including the volatile agent, including narcotic. The other thing is because it involves a cut, the post-operative pain is much worse with a surgical procedure, and so rather than wait for patients to complain of post-operative pain, in the case of this surgical procedure that you talked about, we guess in the operating room how much they might need, and we give them extra narcotic in the procedure to avoid that post-operative pain afterwards. But the pain is much more of an issue with a surgical procedure, and so they need more narcotic.
I'm done with the procedure. I've done a successful suture sculpt, and I tell you, okay, Mark, we're done with the procedure. What do you do next?
So at this point,
I take my endoscope out of the patient. I take my overtube out of the patient. The patient is all yours.
So before that, you say 2 minute warning.
I give you a 2 minute warning.
2 minute warning.
Is 2 minute warning sufficient?
Not really.
Not really.
It takes
okay.
more than 2 minutes
yeah,
to wake the patient up.
I think so too.
But sometimes you don't know, and 2 minutes is more helpful. Usually it takes between 5 and 10 minutes to wake the patient up from the moment you decide to do that. So we talked about the volatile agent. Before you turn the volatile agent off, I increase the flow of oxygen to fill up the lungs and to wash out that volatile agent as well. And that, as I said, takes between 5 and 10 minutes. And at a certain point, I'm monitoring the level of volatile agent. By the way, our monitor tells us how much the patient's breathing out. So when it gets to a certain level that's very low, I know that it's about time for the patient to wake up. And so then I start to look for signs of what we call emergence. The patient may start to move, and then I make sure that the patient is making purposeful movement. For example, they may reach for the breathing tube. Then I know that the patient is almost conscious and ready to wake up. When I tell people about the breathing tube, I tell them you'll be completely asleep when it goes in and just barely waking up when it comes out. And almost nobody remembers the breathing tube coming out. But I look for signs that the patient's just about awake, and then I remove that breathing tube just before the moment where they really regain full consciousness. Mm-hmm. And then within a minute or two after, then we monitor them in the procedure room to make sure they're breathing properly, to make sure that their blood pressure is still fine, to make sure that they're comfortable and not agitated, all these things. And as I said, most of the time, 99% of the time, these things are not a problem, but we monitor them just in case to be extra careful. And then we move the patient to the recovery room once we're sure that everything is okay.
Does the act of actually removing the tube, does that hurt the patient a lot?
It does not. As I said, 990 times out of 1,000, maybe even more, people don't actually remember having it in. The tube just comes out very easily. Removing it is not a problem.
I remember, so I've had 3 surgeries, 2 hernias, 1 on each side, I'm symmetrical, and my neck surgery. I don't remember the breathing tube at all.
It's very unlikely that you would.
Yeah, okay. All right, so now we've left the procedure room and we go into the recovery room.
The patient's safe and we take the patient to the recovery room.
How do you monitor the patient in the recovery room, and how do you monitor them?
We do. So we monitor the patient in the recovery room. The first thing, as always, is just looking at the patient. Make sure the patient's breathing properly. Make sure the patient is responsive to you. This is just simple observation, very important. We put monitors on the patient as well. We monitor the oxygen level. We monitor the heart rate. We monitor the blood pressure.
Okay. Do you routinely put patients on oxygen in the recovery room?
We do not routinely put them on oxygen in the recovery room, although the threshold for adding oxygen by what's called a nasal cannula, the little prongs that just sit just outside the nose, is very low. Any issue at all, we will add oxygen. In fact, oxygen helps us with certain patients that have nausea. Believe it or not, oxygen will help with that. So any issue, the slightest decrease in the level of oxygen, any nausea, the slightest little thing at all, we will add oxygen.
Okay. So obviously you monitor blood pressure, heart rate, the oxygenation level. So once the patient is in recovery, how long should she expect to stay there, and how quickly will she completely wake up?
So half hour to an hour is like a normal time. Once the patient's awakened and once the patient's in the recovery room, our recovery time is generally very fast. As we mentioned before, the things we mainly encounter in the recovery room are nausea issues and pain issues. We take care of those things in the operating room so that the majority of patients don't deal with this in the recovery room at all. However, what we give in the operating room is not quite enough for everybody, but I would say within a half hour to an hour of management in the recovery room, even the patients who have a little nausea, the patients that have a little more pain than we want, are very well managed, and over 90% of patients can go home in an hour.
Should the patient expect, or is it reasonable for a patient to expect in the post-op area to feel 0 nausea or 0 pain? Is that a reasonable expectation?
So I would say 90% of patients, 80% of patients don't have any nausea at all when they get to the recovery room. And the other 10 to 20% that do, we treat that very aggressively until it's all gone. Patients should expect to go home with no nausea at all.
How about pain?
Pain-wise, there's a certain amount of soreness that's inherent in this procedure. We like to say that it's mild to moderate. Anything more than mild to moderate pain, we will treat that aggressively as well. But it's unrealistic for people to expect to go home after this procedure with the same level of pain that they came in with, which is to say 0.
So why is it bad to keep on taking pain medications until the pain is completely gone away?
Because the pain medication has certain side effects. The nausea drugs don't really have side effects that we worry about. Sure, they can cause you to be sleepy, but that's not necessarily a bad thing after you've had a procedure. The narcotics have a less friendly side effect profile. They're safe because we know how to use them. However, they can cause nausea, which we don't like. If we give too much of it, they can cause urine retention. They can cause respiratory depression. So these drugs need to be titrated carefully in order to be used safely. So whereas nausea is something that we can treat and make go away completely, and we do make it go away completely before patients go home, a certain amount of pain is tolerated, but that's got to be a mild to moderate amount of pain. Nobody goes home with severe pain.
Okay, that's fair. Do you insist on the patient urinating prior to her being discharged to go home?
That's not really necessary after this procedure.
Could you explain why?
Certain procedures tend to cause urine retention, and after those procedures, we do ask patients to urinate. Hernia repairs, particularly in men. Bilateral hernia repairs, especially, particularly in men. We know that this operation is associated with a very high risk of urine retention because it's in the pelvis. Obviously, urologic procedures, prostate procedures, bladder procedures, but endoscopic weight loss surgery doesn't require that.
Okay. So, I will tend to agree with you. We've done over 2,000 suture sculpts or endoscopic sleeves, and we've only had one case of urinary retention out of 2,000. And surprisingly, it was in a young man who was 34 years old. That's not the typical patient that you would expect to see it in. What kind of patient would you see urinary retention in typically?
Old men with large prostates.
People like us.
People like us. Exactly.
But I agree with you. It is extremely rare with this
Exactly.
procedure. And
Anybody with a urologic problem besides a large prostate, a stricture, things like that.
Right. And we obviously like to see our patients urinate before we discharge them, but we don't insist on it.
It's not one of the discharge criteria. It's nice, but it's not required.
I agree. Okay. Do you worry about deep vein thrombosis with a procedure like ours?
So we put on something called compression stockings to prevent blood clots from forming in the legs. Deep vein thrombosis is always a risk with general anesthesia, particularly in overweight patients. This is a risk factor. With that said, our procedure is not really a high-risk procedure
In fact, it's very
for
low.
thrombosis. Where you really tend to see it is orthopedic procedures, hip fractures, hip replacements, knee replacements, pelvic surgery for major pelvic surgery for pelvic pathology. With an endoscopic procedure, sure, you're under general anesthesia, sure, the patients are overweight. It's a concern, but it's a very low risk.
And I tend to agree. Our procedures are well under an hour, number one, and our patients are ambulating within 60 to 90 minutes after the procedure
And there's
is done.
no cut.
And they always go home.
And there's no surgical
under
cut,
their own
and it's
strength.
not pelvic surgery. So
Right, I agree. Okay, and in general, how do you participate in advising somebody like me in terms of how to treat the person's pain once they go home? Or how do we handle it?
So you typically choose the post-operative pain modality in consultation with the anesthesiologist. And I know that we typically give them either a patch, a fentanyl patch, which is a narcotic patch, which releases slowly over days, or Percocets, which are just pills that can be taken by the patient according to their needs. Mm-hmm. Mm-hmm. And either one is very reasonable, very acceptable. And some people don't want to swallow pills. Some people might forget. So for them, a patch might be better. Some people will prefer to titrate their own level of pain management. So for them, maybe the Percocets will be better.
Yeah. In terms of pain control, that is really crucial. It's usually the first 24 to 36 hours. In most patients, it is 24 hours. And within that 24 hours, you will see the overwhelming majority of the patients turning the corner. At least half.
I tell them this preoperatively. I say you will have some mild to moderate pain, no more than that postoperatively. And when they say to me, how long should I expect this to go on? I tell them 1 to 2 days. In
my experience, half of our patients, even though we will give them narcotics, they refuse to take them and they just control their pain with extra strength Tylenol, which I think is fine. And when I ask them, why didn't you take the Percocet that I gave you? And their answer typically is, I am terrified of narcotic medications and I don't want to become a drug addict. Can a person become a drug addict by taking these medications for 1, 2, or even 3 days?
It's unlikely.
Unlikely, yeah. And the other half of the patients, they actually listen to our suggestions, they take the Percocet, and their course seems to be smoother.
Although some people walk out of the recovery room not complaining of pain at all. A good
Absolutely.
number of people do.
Absolutely. Why is it that some people are more susceptible to post-operative nausea and vomiting every time they get general anesthesia?
It's hard to know. It's probably a central effect. Just there are questions that you can ask. The same people that tend to get car sick or motion sick on boats are the ones that tend to have post-operative nausea and vomiting. But you can take a history and find out. If somebody's had surgery, you ask them, do you have a history of nausea and vomiting? Why do some people get it and others? It's not clearly known. What is known is that women tend to have it more than men. Mm-hmm. Smokers tend to have it less than non-smokers, I guess because the smoking is inherently nauseating, and so they're used to it, and so they don't get nauseous.
So they get less nauseous.
Smokers are less prone to nausea than not that I'm advising smoking for that reason, but that's a fact. Women more than men, people that have motion sickness, people that have a history of post-operative nausea and vomiting after prior surgeries, we ask about these things pre-operatively in order to better predict.
So in general, for the endoscopic sleeve gastroplasties, or what we like to call suture sculpt, endoscopic sleeve, so we do this under general anesthesia. And the same applies for our revision procedures. So we do revisions of previous endoscopic sleeves. We do revisions of previous surgical sleeves when a patient has defeated that procedure by stretching the sleeve out. And we also do revisions of previous gastric bypasses. So all of these procedures are done under general anesthesia. How about balloons, intragastric balloons? Do you handle the anesthesia differently, or if you could describe what kind of anesthesia do you administer for the balloon procedures?
So there are two.
And why is that different?
So there are two balloon procedures: balloon placement and balloon removal. The balloon placement and removal are almost always done under propofol anesthesia, straight propofol.
So you don't require putting a patient on the ventilator?
In general, not, with one exception, which I'll talk about in a moment. So for balloon placement, let's talk about that first. Mm-hmm. You put your balloon in, and I give a lot of the medications that we talked about before to prevent post-operative nausea and vomiting. The droperidol, the Zofran, the steroid. We give all these things to tolerate that new balloon that's sitting inside the patient.
That foreign object.
That foreign object.
Right.
And patients generally walk out of our procedure room, out of our facility, very comfortable with that. This is done under straight propofol anesthesia. It's almost like an upper endoscopy from my perspective, where you're just looking in the stomach. It's very quick.
The procedure takes about 10 to 15 minutes.
10 to 15 minutes. It doesn't require a deep level of anesthesia. And most of the time, it's very simple, very straightforward, very easy. The balloon removals don't require the nausea medications because you're taking a balloon out. You're not putting a balloon in. And in general, it's easier. However, occasionally, and it's done under propofol anesthesia almost 100% of the time. One time in, I don't know what, you could tell me better.
Maybe 1 out of 20, 1 out of 25.
So very uncommonly, but we do see it. We will see so much food in the stomach that it's a danger to the patient. The balloon will be...
Why is it a danger?
So the balloon is blocking the outflow of the stomach. And even though the patient hasn't eaten for 2 days, if food is sitting there, which occasionally it does, that food can potentially come up and wind up in the lungs, and that's very dangerous. And we do everything we can to not let that happen. We don't let that happen.
Of course not.
And so you will tell me in a scenario like that, there's a lot of food in the stomach, and I'll say, okay, just stop what you're doing. And then in that unusual but not completely rare case, I will put the patient to sleep. I'll give general anesthesia, put a breathing tube in for 5 or 10 minutes, very quick, while the patient's asleep, of course. And that protects the airway from that food coming up, and then the balloon comes out, and then I wake the patient up.
Now, when you have to do that, do patients get the same pain or nausea that they would get after a regular suture sculpt procedure?
No, because
why is that?
Because even though I'm putting a breathing tube in, most of my anesthetic in that case is still propofol, because it doesn't require the same deep level of anesthesia that the suture sculpt requires. So I need to protect the airway just like in a suture sculpt, but I don't require the same deep level of anesthesia. So I don't need to give the narcotic. I don't need to give extended periods of volatile agent, if at all. So no, nausea and vomiting shouldn't be a problem.
You know, the one other situation that we sometimes find ourselves in when a patient has severe intolerance to the balloon and the patient hasn't had time to properly prepare herself for the balloon extraction with 3 days of liquids. So that's another scenario where we may prophylactically choose to do it under general anesthesia and intubating the patient. Yes, because we're anticipating that there will be food there. In that case,
there's such a high likelihood of finding food in the stomach, you would just prophylactically intubate. I agree.
So I remember when we first met.
You can remember that far back?
Yes, I can. So I think I was 17, you were 18.
That's true, and I'm still 1 year older.
Yes. That was 100 years ago. And we were starting college at Columbia. Back in those days, it was still an all-male school.
It was.
The girls were across the street at Barnard. Actually, it's really embarrassing because when I showed up to college, I did not know that it was an all-boys school. And I discovered that when the first day when I went into our chemistry lecture, which was full with 300 people, and I looked around the room and there was not a single woman in the class. And I remember asking somebody, "Where are the girls?" And they gave me a dirty look and they said, "This is an all-boys school, don't you know that?" So no, I did not know that. I was an immigrant.
Well, they were right across the street. They were close enough.
I didn't know these things. I was an immigrant child. I think it was a very late evening because we were planning on sleeping out so that we could be among the first in line to get really good teachers the next morning.
You were number 5 and I was number 6.
Oh, so you were late. Okay.
I remember that. I was late. I was one step behind you, as always.
So we hung out.
That was my good fortune that we hung out right next to each other.
We met. We hung out. Already it became obvious that we were going to be friends. And then
we weren't good friends until your parents came and fed me.
And then around midnight, my parents showed up, my father and my mother. With a lot of food. Georgian food. And that's how we bonded. That's how we bonded, yes. And then the next morning, I think we were, as you said, number 5 and number 6 in line.
Yes.
And we got the teachers that we wanted.
We did.
Did you like college?
Although I couldn't tell you the name of the guy that I got.
No, neither do I. I don't remember it at all either. Did you like college? Was college fun?
I did. It was a really good, happy transitional time. I remember sitting on the steps of the library. If you remember, there were steps.
Yes.
In the center of the campus. And
Low library, right?
That was Low Library.
Not law.
Low.
Right.
L-O-W-E.
L-O-W-E, that's right.
And I remember sitting on the steps of that library, I think it was spring of my junior year.
Right.
And looking around and thinking, I am one lucky guy to be in this place. So yeah, it was a great time. It was a great time. It was a great learning experience. It was a real coming of age in every good sense of the word.
It was not as much fun for me, I must say, because being an immigrant, for me, it was very businesslike. I was not there to enjoy myself. I was not there to have fun. I was there to get the job done, and that was to get an education so that I could get into medical school and be a doctor like my parents.
Well, I did my work, as you know.
You did.
But
you enjoyed yourself a lot more than I did.
I enjoyed what we might call the college experience.
I did not have a college experience because I lived at home. And in order to get to college, I would take a bus, the Q44 on Jewel Avenue, and then I would have to take 3 trains to make it up to Morningside Heights.
And I studied with you in your parents' house, where there were no distractions like there were on campus sometimes.
That's true.
If you remember.
That's true. And we would go at 3 in the morning to the local 7-Eleven. to get some food.
But occasionally I would convince you to stay over with me in the dorms and have a little fun.
Yes. So sometimes
they were accessible.
So sometimes I would stay over in your tiny little room.
You did.
And we would stay out in the library and we would study till 3, 4 in the morning.
That's
or
true.
all night.
The library was open all night.
The library was open all night. Yeah, it was fun. It was fun. Was it hard because there were no girls in the college? Was it hard for you?
No, they were right across the street. I knew where to find them.
Oh, you knew where to find them. Yeah. No, college was a wonderful experience. I learned a lot. I certainly met a lot of a lot of very bright people.
Smart people.
Very smart people.
Some of them we still run into from time to time here and there.
Some of them we still run into. And I met my best friend ever in college that night. That would be you.
That would be me.
Yes.
You are my best friend ever. It was quite lucky that
yes,
fate put us right next to each other.
Fortuitous.
It was fortuitous.
Yes. And then we went to medical school together at NYU.
We did.
Now, medical school, I will tell you, was much more stressful than college.
I found medical school stressful at the beginning because in college you're getting a general education and you need to know something about everything. In medical school, they wanted you to know a lot about a little.
That's true.
I remember when we did gross anatomy, when we started gross anatomy, I was just shocked that you needed to learn every little bump and every little groove and every little hole and the name of it and where does it go and where does it come from and what minor nerve and what minor artery runs through this. I was stunned by this and I had a hard time with this at the beginning. But I think once I got used to that it wasn't college, like you're not in Kansas anymore.
We got really good at it, being you.
You get good at it.
After the first semester, when
learn
you realize what's important and what's not, and you really zone in on it, and
you change your thinking a little bit from college. But once you know how to study, once you know how to learn and absorb information, you know.
I agree.
But it was a.
I remember your first college
transition.
Girlfriend. Dana.
No last names.
No last names. She was a good girl.
She was a good girl.
I
hope she's okay.
I hope so too. And then after medical school, we went in different directions. You went into anesthesiology. I went into first internal medicine and then gastroenterology. And now...
those guys at NYU wanted everybody to go into internal medicine.
They did.
You were an outlaw if you went into surgery or anesthesia.
They did.
Why? Because they were all internal medicine people, the deans were. And so they wanted us to do what they did.
And the internal medicine...
Like when you have a parent that's a lawyer and he wants you to be a lawyer. You have a parent that's an accountant, he wants you to be an accountant. I think it's like that.
The internal medicine people consider themselves to be the aristocrats.
The real intellectuals.
The intellects,
yes.
The thinkers.
They do.
And I will tell you that you have a lot of aristocrats and thinkers in internal medicine. You have a lot of aristocrats and thinkers in surgery. You have a lot of aristocrats and thinkers in anesthesia. Every field has its share of really, really super smart people.
I've worked with plenty of super smart surgeons in my life.
And
sure.
Whatever fascinates you and whatever interests you, that's what you should be doing.
Because that'll make you happy and that'll make you good at it.
Absolutely.
Right.
Absolutely. And I'll tell you that I've been doing endoscopic weight loss now for about 7-8 years. And I did about 30 years of gastroenterology, and I love gastroenterology. I love practicing gastroenterology. I love teaching gastroenterology, which I'm still actively involved in teaching at NYU, New York University, at Bellevue Hospital. I loved practicing it, and I loved learning new fields as they became available. And then when endoscopic weight loss, when the technology became available about 7 or 8 years ago, I immediately found it interesting. And doing what I do now, it makes me feel young again.
And I look forward to our days together.
I do.
It's work, but it's also very pleasant.
We have a group of anesthesiologists.
Certainly the happiest work situation I've ever been in.
And me too. We have a group of anesthesiologists that we work with. You are my director. You are my lead anesthesiologist. And the days when I'm with you are the most fun days.
They're good days.
They're great days.
I look forward to coming to work.
They're great days. But I'll tell you what I do now, endoscopic weight loss or bariatric endoscopy, there are no textbooks in this.
You can write the book one day when you're
one
ready
day
to slow
when
down.
I'm ready to quit and retire, which hopefully will be never. But what makes it exciting is that it's all fresh.
Everybody has their time, my friend. Everybody has their time.
It's all fresh. It's all new, and we're making the rules as we go along. That's what I find so invigorating about it. And I really hope that God gives me the strength to work until my last day. That's what I want. If I can ask God to give me the strength and the knowledge and the ability to work until the last day, that's what I want out of life.
Okay. Different views for different Jews.
You got it.